kind of following suit with the pandemic and everything going on, where mental health has really been at the forefront of everyone's minds, I think. And it's really been something we've been talking about more and really kind of inserting it into everyday conversation, which is fantastic and an absolutely great opportunity to bring in mental health services for the ride along with us on this masterclass series, where we're going to be interviewing Lieutenant Navy Megan Churnside, who is the General Mental Health Lead for Mental Health Services at 31 Health Services at CFB Borden. So Megan, thanks so much for jumping on for this interview today and answering some questions both from health promotion, so some questions we often hear when we're teaching kind of in the community. As well, we have a few questions from the community themselves, so some questions around leadership and mental health services and accessing resources during the pandemic. So could you just introduce yourself? I know I kind of introduced you already, and maybe a bit of your role at Mental Health Services.
Okay, so thank you very much, Braden. So like you said, my name's Lieutenant Navy Megan Churnside. I'm a mental health nursing officer here at 31 Canadian Forces Health Services Center. My role specifically is the General Mental Health Program Lead. And so my job is to basically oversee our general mental health program, help liaise between primary care and mental health, so like your family doctor and mental health, assess patients to see should they be more psychosocial, which again is a little bit separate. Psychosocial services is different than mental health services. Mental health, you require doctor's referral, whereas psychosocial you don't. So sometimes if doctors are in between or if they're not sure, I'll do an assessment and then then speak with my team and present my findings. And we work to with primary care and with psychologists, psychiatrists, social workers, other registered nurses to come up with a care plan. Of course, always with the patient's goals in mind. We don't force care in any way. So that's a lot of what I do. And then we come up with a plan and work with our members. We also do outsourcing. So like if we don't have the services in-house or if there's a specific need that a patient needs met and we don't have it, I work with my team to get it outsourced to someone appropriate within the community. I liaise and educate chain of commands, do a lot of education at different units, teaching, and of course, and I see patients my own self right on top of that. So
wow. You are busy.
People, when they first get to know us, they'll come in through sick parade because they're not having a good time, or maybe they're referred by their staff or friend, or maybe their spouse, something like that, saying, you know what, I think it's time you get seen. So if you're wondering, like, how do I get help? Where do I start? Yeah. Very baseline, if you don't know, you can come into sick parade and you can say, I need to see someone from mental health or psychosocial. It doesn't matter the words. There's no wrong door entry, more or less, right? So, and the med tech or the PCN, the primary care nurse who's on call will know to call, it's called an intake. And that's either a nurse or a social worker who's going to sit down with you, help you kind of regulate your emotions enough, because when you come in, it can be stressful. So like if you need to have a good cry for yourself, or if you need to vent, then you can do that. And then it's a quick assessment to make sure you're safe. And then we do up a referral if it's for psychosocial services. So that's more short-term counseling. It could be alcohol addictions issues. It could be marriage issues. It could be parenting issues. It could be you're not getting along with coworker, you name it, they do it. And it's generally 8 to 10 sessions in house. Okay. And it's like non-complex. So that's psychosocial. So you can get a referral from your doctor. You can self-refer. So you don't need to actually see your doctor. It helps because we get more of a medical picture. But if you really don't want to, you don't have to. Okay. And you go through the intake. Another way would be to just book, if it's not an emergency, then you can book an appointment with your family doctor or your MO or PA, a nurse practitioner, whoever you see, and they can send a referral to psychosocial. Kind of an add-on to that would be the mental health side. So if they're thinking it's something a little bit more than just a situational crisis, if it's something like trauma related, or if there's something more, like there could be the potential for more like a mental health diagnosis to come from it, that's when it gets sent up to my team upstairs. And that one's definitely through your doctor or nurse practitioner or physician's assistant.
Okay. So basically you walk into 31 Health Services, you can either make an appointment beforehand or just walk in and you'll see someone kind of right away, where the nurse assesses you, and then you'll either go to that psychosocial, maybe shorter term assistance, or that longer term come upstairs and maybe chat with you or someone from your team and get on a care plan that works for them. Is that?
Yeah. So like with intake, generally, I mean, sometimes it can take longer. Generally, it's supposed to be about a half hour. So it's not like getting the therapy at that time. It's trying to find our arcs of fire and what to do, right? And if a social worker or nurse who's working intake that day feels that it's something a little more serious, or there could be a medical aspect to it, then what they'll do is they will bring you over to the CDU and have you book an appointment, if it's an emergency with the sick parade doctor for the day. But if it's not an emergency, they'll have you follow up with your primary care provider, and then you can have that conversation that would encompass like all of your feelings, what's going on. Is it something physical? Is it hormonal? And that's also something that we do up in general mental health too. It's one of my roles as a nurse is to figure out like, okay, is it something, is it situational versus is it something more organic that's going on, or something that's more indicative of a more serious condition that would need more advanced treatment, right? So.
Right. Yeah. Okay. Sounds good. When we're talking about, who's entering 31 Health Services, who's getting access to your resources, who does mental health services serve? Like, obviously serving members, veterans, who you may not know.
It can be confusing. So once you hit the veterans side of the house, that would be Veterans Affairs. So like 31 Canadian Forces Health Service Center, we service active serving members and reservists that are under contract, right? So either the contract greater than 180 days. And so that's why it's important. I mean, it's on your file and everything that we have access to through our health information services, but just remind them, like, what type of reservist you are, if you're on contract or not. We don't have a habit of like turning people away, obviously, but if say you're like a contract less than 180 but what's wrong with you can be contributed to service, then that's taken into consideration. And we liaise with, if I'm not sure, I'll look up policy and procedure, I'll check all the references, and then I would end up working with the civilian community, because perhaps, all right, like, although you're a reservist, but because of your contract, it's so short that it wouldn't make sense for us to follow your care. And then you might need to go back to your primary care provider in the community, but I would help liaise with that. And of course, Reg Force members, right? Always. We don't care for families, but as a caveat to that, we do couples counseling.
Oh, cool. I didn't know that.
Yeah. And a lot of people don't know that. Oh. That's psychosocial. Like, we can do some of it up in general mental health, but generally marriage counseling is a psychosocial function. If you're not comfortable seeking services, say, for example, if I'm not feeling well, I'm the team lead, so really it would be inappropriate for my team to treat me. So say if I need help or I need counseling or there's something going on, I would be externally referred to somebody in the community that could see me, because you want to keep that confidentiality and appropriateness. So say if there's anybody who works within the building, or maybe it's someone of a higher rank and you just don't, and you know a lot of people and you just don't want to be seen. We're trying to fight stigma, but we also want to maintain medical confidentiality, right? So if someone has any concerns about that, then what we do is we'd refer in the community, and we have a nurse that follows those members like over the phone kind of thing, and just make sure that that connection's made and we follow their care. So that's here in the building. For your family, for next of kin and dependents, there is a SIF map, which I'm sure like you guys plug all the time. And that's 8 to 10 sessions with a nurse or social worker out in the community. And we don't have any insight into that unless the person gives them permission to tell us, and if they think it's going to be more than 8 to 10 sessions, then that's generally not psychosocial. It's kind of pointing more towards a mental health diagnosis or issue that they'd want us to see, right?
Mm-hmm. Okay, that makes sense. What about like civilian staff or D&D staff that aren't serving members or reservists? You wouldn't see those individuals as well?
No. So what I do, like, because I do work with a lot of civilian staff and public service and contractors, is just as a nurse and knowing, we're always pointing people in the community to the different services. If I'm not sure, I can't provide any official care. It's not our mandate and it's not appropriate. But like, I mean, as always, I would let them know what is available in the community. So if someone were to call with questions, it's not really, again, it's not within my AOR to kind of take care of, but there are resources out there for civilians, but it would be much like what it would be like for the general population, like in Ontario, right? Or whatever their collective agreement, if they're under Sun Life or whatever program that they happen to have.
Yeah, right. So like an EAFP or EAP program, very similar. Yeah. Okay, so it kind of sounds like, only serving members or under certain reservists, things like that can access care, but it's almost like, anyone come to get mental health services, to seek assistance, and we'll kind of guide you from there. We're never going to turn anyone away. We're never going to let them high and dry. We're going to get them the resources they need.
One of the biggest ones would be we get a lot of questions with reservists, and that one's just a bit more complex, and so that one, so for sure, when in doubt, check them out. When in doubt, so that's it. Yeah.
Okay, sounds good. In this climate that we're currently in, with a pandemic, with working from home potentially, with so many additional stressors in our life, I would love to get your take on how important mental health is for our overall health.
Yeah, I think it's a conversation that like a lot of people are really getting into lately. And of course, we've been fighting the stigma for years, and a lot of more like celebrities are sharing their struggles and everything. Like I've been nursing now since I graduated nursing school in 2006, so I'm not a new nurse. And there's something that we were taught in nursing school that still kind of resonates now, and it's that number one, well, mental health is health, but your physical health doesn't always, it can, but it doesn't always have an impact on your mental health. But your mental health has an impact on everything, and they're really interconnected, right? So if you're having, like, you know what I mean, if you do have an injury and it affects your function, then it can have a big detriment on your mental health and how you're doing and your coping and your resilience. So being healthy and having good coping mentally is really important, because life is a series of wild and crazy things, and we never know what's going to happen. Yeah. And we have to like build up a reserve, right, of energy and as much knowledge as possible to either learn to recognize when yourself or a coworker or friend isn't doing so good, or knowing when to wave the white flag and get a bit of help. Mental health kind of affects and touches every part of healing and being, right? We see a lot of members that are like feeling burnout from work, and they're wondering like, is there something wrong with me? And when I actually sit down with them and we sit and we chat for a while, and they're like, well, like, I'm having trouble at home. And then there's the pandemic. And so your normal coping of time alone, or going for PT, or going and doing stuff on the weekends to bring a bit of joy to your life, all that's kind of quashed now. Going out with the boys and playing sports, or, just any of this normal stuff, because humans are social creatures. We can't do that. So now, even in treating members who are going through situational or even like more organic depressions and stuff, it is a lot more challenging, because we have to find different ways to kind of treat what is, because we can't really change the environment we're in right now. Right. So it's like a radical acceptance, but that's not always easy. And there's no shame in reaching out and getting a bit of help, because you can only help yourself move forward, right? Exactly, right. You can only do, coping strategies and social interaction can help to a point, but at what point do you say, wave that white flag and say, no, I need that additional help, and that's okay, right? So I think that's really important, kind of as a takeaway to note that, the services are there, and they're there for a reason. Yeah.
With services and so many services, I know from a health promotion standpoint, a lot of our services have now become virtual. Has anything been changed or shifted since COVID has occurred? Has anything been taken virtual from mental health services, or has that changed at all?
That has been a big part of kind of what shifted. Number one, when COVID first started a year ago, it was like only see patients in person if it's an absolute necessity, like life, limb, or eyesight kind of thing, right? And of course, just because something's mental health doesn't mean that it's not that. I mean, it can be, especially if someone's having a suicidal intent or whatnot, right? It can be a challenge. And to assess that, you want to get their affect, you want to get like, a sense of person and being there. So in one hand, the virtual care that we've implemented is good. It's just like this, me and you talking right now. Our psychologists, psychiatrists, our social workers, they're seeing patients virtually either on the phone. Like what I do a lot of phone appointments because they were trialing different safe methods to be able to provide appropriate and not breach confidentiality. So all the computer nerd stuff to make sure it's safe enough to do care over video. And we've trialed a few things, and now we have 2 different programs that we were using, and I think we're actually going to be moving to Microsoft Teams. But yes, we've been seeing patients virtually, like via video, which is nice because then you don't have to like leave the house if you're far away or like drive to the base, and there's less contact and risk for transmission, which is good.
Yeah.
And a lot of people are more comfortable in their own house. They don't like, there's not that risk of feeling like someone sees you or whatnot, which is a positive. And it's better than phone because I can see you. I can see how you're reacting to what we're talking about. I could see your facial expressions, and it gives us a lot to go on and just being human and interacting. So yes, really, I mean, for myself, 99% of my patients right now are over the phone.
Wow.
And so like I think I had one, like my first in-person patient in months, like maybe a few weeks ago. Of course, you can be seen in person, but you have to go through, calling the Keo line, or if you're already with us, then I have to okay it for my staff just because of the new variants that are in the area. We're trying to minimize as much contact as possible, but also knowing that certain therapies such as EMDR, which is more advanced therapy, is very difficult. It's a skill set to be able to do it virtually, and it's more appropriate in person, right? But we're doing everything virtually, and people are getting connected, right? So
awesome. That's amazing. So if someone's watching this now and wants to make an appointment with mental health services, their best bet would probably be to call then to avoid that exposure a little bit.
Yeah, so I mean, anybody who enters the building, either staff, contractor, or patient, has to go through the questioning and screening downstairs, right? Because obviously there's some health conditions, mental health or psychosocial or primary care, that we're going to need to see you in person. And so we have our DTU downstairs. We have the HEAL line. So if you don't know where to start and you're not already connected with services, it's just like calling for sick parade, right? You want an intake appointment. So what you would do is you would call the HEAL line, and that's extension 4325. Sorry, had a newfie moment there. And 4325 to call, and then they'll call you back and they'll put you on what's called our on-call schedule.
Okay, amazing.
Right?
So kind of removing any barriers to getting assistance from you guys. That's awesome. Have you seen an influx of patients or clients since the pandemic started? What'd you say?
It's hard to say because I took over the team lead position or the program lead position just as like a year ago now.
Oh,
right?
okay.
So for me, it's hard for me to answer that. I would like to say yes. I mean, as any other healthcare sector, like, staffing is an issue. And then, with all the changes and all the challenges, and with regards to staffing, like, for example, I have a little guy at home, and if he's sick, then automatically I'm not allowed to come in and test unless he tests negative.
Right.
Even if I have care for him, the rule now is anybody under your roof. So it's like, okay, well, we're trucking along okay until something like that happens, and then however many patients I were to see in that amount of time it would take me to get the clear to come back would be backlogged. So there is some backlog, but there is a lot of support, and we're doing quite well. Also, there is the SIFMAP program. So sometimes if our wait lists are a little bit longer down in psychosocial, we'll ask someone, would you be more comfortable, like if the wait list is going to be a month and you're feeling it's more urgent, then are you comfortable with us outsourcing? It could be faster. Or if it's something that's kind of, you just want to vent about, we do our assessment to make sure you're safe and work with you to see what you're comfortable with, but also being like, well, is SIFMAP something you've considered? Or maybe you're okay waiting a few weeks, or maybe I'll just do a check-in here and there with you and bridge you until we can get you in with someone on a more regular basis. But we work together as a team to find what's best for the patients, right? Yeah. It's not just us. And there's also your primary care provider too, that you can book in with. And so there's people that will track you until we can get you seen by somebody to provide a continuity of care, right?
Right. And it's, you're never leaving someone high and dry. There's always that avenue. And it sounds like you kind of listen to the member or the client who's coming in and kind of assess where they want to take it. It's not all about mental health services. It's all about the patient, right? So that's really good. You've already kind of answered this already. You do offer emergency assistance. So if I'm in an emergency in this moment, I can call you. I can get an appointment immediately, as well as you offer kind of more formal, phone in every week, or those more scheduled appointments, right? You do both?
Yeah. Yes, okay. We do. And so for my department upstairs, like for general mental health, it's not generally urgent. Because by the time you come to see us, you've already seen a doctor, maybe a nurse, maybe a social worker. So by the time you get referred to us, the initial crisis would have been it then, if that makes any sense, right? Yeah. So if you're in an acute crisis, there's a death in the family, you're really upset about something, your coping has just gone down to zero today, trouble at home, like if you're having suicidal thoughts or self-harm thoughts, or heaven forbid, homicidal thoughts, like these things are part of the human experience, and you can't always control them. So from 7:30 till 3, Monday to Friday, we do have someone on call. Okay. That being said, if it's a medical emergency, like if you are suicidal and you have an intent and you have a plan and you have the means and you're scared and you don't trust yourself, or you see someone else, like a coworker or someone who's expressing this, a lot of people are afraid to make a big deal of it. They're afraid to either embarrass the coworker, embarrass themselves, whatever it is. And honestly, suicidal intent, ideation is different than intent. Ideation is kind of thinking about it, and intent is coming up with a plan, right? So that kind of shifts. And if it's that, then you're not stable and you don't trust yourself and you're hurting that badly, I would recommend calling 911. Okay. It's not to say that you can't come see us, you can. But if I have someone, I work with them, and if I fear for their safety and if they're afraid for their safety, then we'll get them higher level care and get them assessed. But again, if it's like a Friday night or you're staying in the shacks and you're feeling that way, or a friend is feeling that way and you're not sure, if you told me, you know what, Megan, my arm's hurting, my jaw hurts, I have a history of cardiac problems. Is it a heart attack? Yeah, I'm not sure. I'm not just going to be like, oh, well, I guess we'll see. No, well, because that could be a medical emergency. Yeah. So I would call 911. And suicide is no different, right? It's just there's that stigma attached to it. And in the end, they're going to assess if you're okay or not. And then they're going to get you the services, or they're going to provide the feedback to us to be able to help you, right? Exactly. Just like a heart. Yep, just like a stroke, it's not something we mess around with, right? It's serious. And I do a lot of education with my patients with regards to suicidal ideation and the difference, because a lot of people think the minute they say they have dark thoughts or they have thoughts of wanting to end their life, they think that I'm just going to automatically send them to the hospital. That's not true. Some people can be chronically suicidal but never have an intent or not have a plan, or they might be suicidal and have a plan but not want to act. And so part of what we would do here is do an assessment, a safety and risk assessment, and come up with a safety plan. And a lot of times, most times we can avoid going to hospital just based on their presentation. And if we need to send them to hospital, generally by the time we're done our assessment, they understand. Right. And they're okay with it. It's just like I said, like a heart attack, like a stroke, like any other medical emergency, right?
Yeah, exactly. Amazing. A question here kind of comes from my experience working with members and hearing stories around Bell Let's Talk or other avenues in which we teach mental health. So I've heard that seeking mental health help with therapists or counselors, you kind of have to find that right fit of someone who you can, relate to and have that common relationship with. So how flexible is mental health services in getting members support that fits their needs, or getting members the counselor that fits them? How flexible are you guys?
I want to say, and maybe I'm biased, right? But like when I'm doing an assessment with somebody, or when I'm coming up, it's always like, okay, you get their health history and you talk about what's going on, and then I will ask, do you prefer gender? Is there a gender? Because maybe there's something that's happened in your past, and maybe being either with a male or female provider, it might not be a good fit for you. And we don't judge that. Or of course, languages, right? So if someone's primary language is French, we're going to find we have some French providers, right? If, it really depends, or what type of therapy. So I can recommend a few different types. I might say, well, EMDR is going to be great for you, but you might say, no, I'd rather do I'm not ready for that. I'd rather do cognitive behavioral, we'll teach you what the different ones are. In the end, you are in the driver's seat. It's your healthcare. It's not mine.
So moving into more of the questions from members who have kind of asked question on our social media, kind of goes, I added a bit to this question from my own personal experience. But I recall interviewing a member for Bell Let's Talk who mentioned they had a huge fear. They've now accessed mental health resources and they go to counseling very often. But initially they had that fear that when they walk into that room, they have to divulge all of their past, all of their hardships. They have to just lay it all on the table the first session. And I think for a lot of people, that's a big hurdle to get over when they think about accessing assistance of any kind, really. So can you speak to kind of that relationship between a counselor or mental health support worker or whoever it is that is in the room with me, kind of speak to that expectation, I guess, from a mental health perspective?
So just to clarify, so the pressure that they would feel to be okay, not only do I need to talk about why I feel I'm here today, but everything I've ever been through. Yeah. In the first session. Yeah. I can't, once we're saying this isn't during an intake, this is okay, I'm booked with Megan. Yes. This is my first time seeing Megan, or one of our other staff. A lot of times what I'll do is I'll get to know somebody. You know what I mean? Married, not married, how long have you been in? You know what I mean? Do you how many dogs do you have, or hamsters? That kind of thing, and get to know someone. And then I'll just allow them to talk. And everybody might laugh and say, what, Megan, you're not going to talk? And I'm like, no, legit, most of my job, 95% of my job is sitting and listening.
Right.
And so they can talk about what they want. If they need to vent about everything and anything, they can. If they want to, and what'll happen is, it's my job as the nurse, because I only have, say, that hour, is to narrow down, okay, life, limb, or eyesight, or the bottom of Maslow's hierarchy of needs. What do we need here today for you to feel safe, and for you to be able to cope with today, leading in tomorrow or to next session? So first session is kind of getting to know each other, right? And even over the phone, still it's getting to know each other. And then we do something, either not always the first, but usually by the second meeting. If we meet again and someone's still kind of in crisis, maybe they're going through, a posting that's really bad, or someone passed away and it's still upsetting, then we can kind of have another venting session. But within the first few sessions, what we do, it's called a psychosocial assessment. And what that is I explain it is it's a detailed health history. And it can take a couple of sessions, or it could take a really good hour and a half of sitting down. Where are you from? Like, how were you raised? How many brothers and sisters do you have? What kind of illnesses were in your family? What kind of stuff happened growing up? And we touch on all those aspects of your life. And I always tell them, if it's too much for you or if it's overwhelming, we could stop at any time and pick it up. Or if you don't want to answer a question, you don't have to. And at the beginning of each session, I explain to them that this is medically confidential. That's also what's really important. To know that what we talk about stays within the circle of care. I don't share it with your chain of command. Mm-hmm. There's only 3 times when I have to take it kind of outside the circle, and that's number 1, if you have suicidal intent, if you have homicidal intent, because we can't have that, right? Or if the welfare of minors of 16 and under is in question, then we have to get CAS involved. And I tell everybody at the beginning of each session that, other than that, I will lose my license if I divulge something inappropriately. So like, we are not allowed without your permission to divulge things to the chain of command. So that's important. So we set those expectations, and that at the beginning, generally in the first session. And so then we just take it from there and we assess. And as someone kind of talks about their health history and talks about their functioning and how they're eating and how they're sleeping and how their PT is and their motivation and everything, and their supports and their lack of supports, their drinking, any drug use, once we suicidal ideation or history or attempts or self-harm, their coping, we touch a little bit on everything. And by the end of it, generally the clinician will have an idea on what direction it'll go, and then consult with the team and the patient, and then decide, cognitive behavioral therapy is going to work for this person, or they're not there yet. So maybe motivational interviewing, or maybe they just need supportive counseling, more psychosocial. Maybe we thought it was mental health, but really it's not. And again, we work with you. It's not something sneaky in the background. Like, we're open and honest with our patients, and we all kind of bring all of our combined knowledge together to come up with something that's going to work for each person.
Right. Okay. Awesome. Yeah, I hear this one a lot of it's almost a maybe stigma, maybe fear, I don't know. But accessing mental health services or resources is overwhelming, because you kind of have to, you feel like you have to share all your hardships in the first session. And what you're making it sound very, share at their own terms, share little things. You don't have to get to the meat and potatoes of your struggles in the first session. It's, we're building a relationship here, and we're going to move forward how the individual wants to move forward. So that's very good to hear.
It's about trust, right?
Yeah.
It's all about trust. And if it's your first time meeting me, you're not going to want to tell me everything. You're going to want to suss me out, or whatever other clinician you would suss them out and see, do I trust this person? Am I having a connection? Are they understanding me? Would never want to force anything like that. Like this, it can happen over time. There's no rush, right?
Perfect. Well said. All right. So we've got, what can I do, or what can an individual do in a unit to promote mental health or mental wellness? So if I'm maybe, let's say, a leader in a unit, what could I do to promote mental wellness in my unit, would you say?
Wow. That could be its own week-long.
I know.
That's actually a specialty within, I think, leadership roles. There's a lot of courses. So what you can do, I'm not sure how many courses you guys provide for leaders. There's that used to be like the ACE model, suicide intervention and prevention models. There's a lot of R2MR that we get taught from boot camp on now, which is great. But as a leader, being aware of the resources, being aware of the policy and procedures, and not being ashamed, not to say, obviously, it's inappropriate for you to open up about your own struggles. The biggest thing I can say is the morale of your troops within your unit or under your command is huge. So them feeling like not a number, and it's always that line we always hear, and a lot of us will end up rolling our eyes, like, know your troops and promote their welfare. It's something that's drilled into us from the minute that we go to boot camp on, but it's true. You kind of have to take the temperature of your unit and of your people and how they're doing and check in with them quite often, not to say to force the conversation, but to let them know that, you know what, like we're aware that mental health, either we believe it is or not, it's a thing. And I'm glad that the culture is kind of changing, and now there's leadership courses that you can do to help promote the mental health and welfare of your employees and your subordinates. There's a lot of resources that Canadian Forces does offer. And that's something else, like I'll get calls from different chain of commands, like, what's the policy if I think someone is having a drinking problem and I don't want them to get in trouble, I just want them to get help? Well, there's a lot of nuances and ethical considerations with that, but there are policies and procedures, and they can call and they can ask, and we can educate and provide guidance. We do that. Or like, they're concerned about a subordinate's well-being. Can I order them in for a check? Yes, you can, but they don't have to participate. So that's something else that, like, as a chain of command, you might send Corporal A in because he's really angry, and you want to make sure that he's okay mentally first. And then I might see him and say, why are you here? And they say, my chain of command sent me. And I say, do you consent to this appointment, or do you want to continue? And they'll say no. And I'm like, okay, I don't push it. Yeah. Nope, that's it. I signed the piece of paper saying that they showed up because the order was for them to show up. Right. But then I educate them quickly before they leave. Sometimes they'll stay, but I'll educate them that now, because your chain of command did their due diligence in trying to get you help, if it's an anger issue or any kind of other issue, that it then can become a discipline issue. So it's kind of them, and it's good of them to send them our way first, just to make sure, because we can help with that. But again, you have your right to self-determination for care, and if it's not something that you're interested in, then we won't force it. And then chain of commands will come back to me and kind of be like, okay, now what do I do? Yeah. And we just it's all policy and procedure, right? But there's a big world of it, and trying to search it on the DIN can be difficult, right?
Mm-hmm. Yeah, another question we have is actually related to courses available for mental health in the CAF. So maybe I'll speak to some that I'm aware of or that we teach, and you can kind of fill in the gaps there if you have any more that you know of. So from a course perspective, Health Promotion does teach mental fitness and suicide awareness. It's a full day in-person course. We do not teach it virtually, so we aren't teaching it right now the full day. We're not giving out certificates for it right now, but once we go back into in-person teaching, we will be able to do that. So that is a supervisory level course where you can learn kind of the ins and outs of leadership from a mental health perspective, how to speak to someone who you think might be having suicidal ideation or intent, or how to help someone who's struggling, really. So that's a course. I know through the chaplain services, there's the Sentinel program, so where you can kind of have a very similar course structure to MFSA, where you learn the ins and outs of mental health and how to help someone. And then there's also R2MR, which is very similar. I think it's a little longer of a course, if I'm not mistaken, a week or so, 3 days, something like that. And that can be another avenue you take if you're looking for additional courses or information on mental health. Is there any that I missed that you know of, Megan?
Those are the core ones that we recommend. And so there's a reason why it's integrated into the PSP or to the Borden Morale and Welfare Services, right? I'm not really aware of any more advanced ones, aside from ones, say, that I would sign up for myself to do as a clinician. That's military specific, right? So there's always education out there. There's also there's apps. There's lots of apps. We have there's actually a list we provided before, and I could probably send it to you after some recommended apps that you can download. R2MR also has an app.
Yes, they do. Yep, you're absolutely right.
Welcome to 2021, right? But they had it out for a few years, I think. So there are some apps that we do recommend, and they're quite good, especially if someone's more into tech. It can be good for them. And we do have a list of recognized ones that we find helpful that I could provide to you.
Awesome. Yeah, that'd be great if you send it my way. I can share on social media afterwards too, if possible. Alrighty. I really only have one last question for you, and It's my own personal question. I ask it to every single person who I talk to mental health about. So if someone is listening right now who is struggling, what would you tell them?
It's funny. And I think I touched on this when I did the Bell Let's Talk. Yeah. Like, it was one of my biggest things because I had someone tell it to me in the past. And so if you're sitting there and you're struggling and you don't know what to do, I find a lot of our people are really good, and we join the military because we generally want to help people. Some people because they want to blow stuff up, like the combat engineers, but I mean, generally we want to help people, right? And serve our country. And so if you had a close friend come to you and explain to you, I'm not eating, I'm not sleeping, I have to go into the bathroom at work and cry, like I'm not functioning, I'm not doing okay. What should I do? And if you would advise them, maybe you should get help, then take that advice and turn it around. You have to be your own friend and be like, you know what? It's easy for me to tell somebody else what I know is probably the right thing to do, but it's really hard to take my own advice. Yeah. But honestly, as difficult as it is, taking your own advice and coming in and getting help. Some people, I mean, sure, their coping can be fine and they can do really well, but if you're really struggling, a lot of times I think people know when it's time, and the services and the staff are here to help. And so just be your own best friend and take your own advice, I guess.
Yeah, perfect. I think we often kind of forget that of, we should be talking to ourselves like we're talking to our best friend, and kind of using the same language and being our own kind of advocate for ourselves. Alrighty, so those are all the questions I had. Is there anything that I kind of missed that you wanted to share through this platform?
I think we actually covered a lot.
Yeah.
I think one of the biggest thing that I hear, and I've heard it like my entire career as a nurse, and then now a bit later in my career having specialized in mental health, a lot of people wait 5, 10, like something will happen. It doesn't necessarily have to be deployment related, but something will happen and they wait to get care because they're afraid it's going to negatively affect their career. That's one of the biggest, it's stigma, but they're afraid, if I go to counseling, then I'm going to, it's going to affect my career, or, that's the biggest thing I hear.
Yeah.
And it's not to say that any health condition can affect, right? Like, so if I develop asthma, or if I, develop, chronic back pain, as I march on in my years in the forces, this kind of thing, that can affect my career as well, but we're more likely to go get help for that, right? What would affect your career and your home life and your ability to enjoy life and to live your best life and to reach your goals, whatever your goals are, if you don't get help, it can negatively affect your career, because your ability to cope and your ability to perform your duties and your ability to, be the kind of partner, parent, aunt, uncle, cousin, whatever your family situation is, your ability to be that person and be yourself can be severely affected. And so by coming to get help, it's not an automatic career's over. People, if that was true, then we'd have a lot less people in the forces right now, because, we're quite busy. And by getting help and getting the resources and getting it looked after, it just gives you more of a chance to be able to get healthy and to prevent further injury, right? It's like, well, my leg's hurting, but I don't want to x-ray because I don't want it to be broken. Well, it still might be broken either, right? And so just ignoring it's not going to make it necessarily heal better. Yeah, maybe I can go on, maybe it'll heal. But I would recommend coming in and getting it seen to earlier before it does have a further negative impact on your life.
Yeah, absolutely. Very good advice. Alrighty, I think that's all the questions I have for you, Megan. Thank you so much for joining us today on this interview kind of platform. If there's more questions that come from this, we'll absolutely reach out again and grab you for another interview. But as part of health promotion and CFB Borden, we kind of want to say, we're huge advocates for mental health. We love this kind of relationship that we've been building to share all aspects of mental health, from the prevention side to that more clinical side. I think we're kind of bridging that gap to get people the services and the information they need. So I love that we're doing this, and I hope that it's helping, even if it helps one person out there. You know, we've done something good today, so you know, get them the help that they need. So absolutely, we'll continue to promote mental health services and to continue that relationship. So thank you so much. And if there's any questions you have for me, we can talk after this. I press end, but hopefully everyone else watching out there got something from this, and have a great day.
Okay, thank you. Bye.
Thanks.